for coming for this session, for this event, and once again, thanks for our panelists. For the next hour and 15 minutes, we're going to discuss how we can leverage data insights to improve health financing and delivery in low and middle income countries for health. One of the key benefits of digital technology is that it stimulates access to better data, which can facilitate the financing and delivery of health. And of course, so you have the collection of data through digital means, but you can also, of course, collect data through other standard means, which can also inform learning around universal health coverage. And as we all know, in these times, you can hardly have a session without talking about COVID, because that is the sign of the times. So we will certainly be reflecting also on the impact that COVID has had on the way that we do things. So let me just repeat what the main focus is, to share lessons about innovations in data collection and analysis that can help address issues regarding sustainability of health financing and delivery. And we do hope that at the end of this session, that we'll be able to expand the scope of learnings for countries that are embarking on data analysis. We are fortunate for this event to have a very diverse panelists, coming from different parts of the world. We have His Excellency Dr. Matthew Owiri, Deputy Governor of Kisumu County in Kenya, Dr. Lydia Selby, Chief Executive Officer at the National Health Insurance Authority in Ghana, Diana Muhongewa, Health Economist at the World Health Organization, Manjiri Bawalka, Manager, Health Financing Team in the Department of Strategic Information at the Global Fund, and Marion Cross, Senior Economist at the Global Financing Facility. My name is Kwesi Buahine. I'm Director of Advocacy at PharmAccess, and I will be the moderator for this event. So for the event, we have two parts. Part A will be an interaction that I will have with the panelists, sort of interview mode. And then part B, hopefully we will have enough time to take questions from the audience. So for the audience, if you have feedback or questions, please share them via chat in Zoom or in Attendify, and we will look at the questions and interact with our audience on it. So to begin with what I call round one. Certainly, looking at impact of COVID on the way we do things, on health financing, on the economy. Matthew, if I may begin with you, COVID has both health and economic impacts. Can you share the economic impacts of COVID on Kenya, and for that matter, Kisumu County? And maybe for the sake of the audience, could you also explain a bit about where Kisumu is, for those who are not aware of it?
Thank you, and a very good evening, morning, or afternoon, wherever it is that you are tuned in from. Kisumu is in Kenya, the third largest city here. We only have three cities. There's Nairobi, there's Mombasa, and then there's Kisumu. Now, Kisumu is a county. We have 47 counties. Kenya is divided into 47 counties. So you'll have what you have, elsewhere, devolved units of government. So the county of Kisumu is, of course, led by a governor and a deputy governor, but you also have a senator who sits, in the Senate, basically in the capital. We are about 350 kilometers to the west of Kenya. Kisumu is basically the largest city by Lake Victoria. Lake Victoria, as you all know, is the largest freshwater lake in the African continent. Very well connected to the rest of East African countries. Through the lake, we have a very robust maritime trade and transport across the lake. Basically, it is home to quite a number of inhabitants of Western Kenya, okay? So that's where we are. In 2021, November, we will be hosting AfriCities. AfriCities is, an annual event, a biannual event hosted in cities in Africa. It's basically an association of local governments and cities in Africa. So Kisumu will be for the first time hosting this event in 2021 for the first time in a middle-sized city. And so I take this opportunity also to welcome all of you to come to Kisumu and participate in that wonderful event. Now, to your second question of how the economy of this country, and particularly this county, has been affected by COVID. In March, when the first case was reported in Kenya, we as a country decided to put in place measures to control the spread of this pandemic. And the spread was faster in Nairobi and in Mombasa. So basically, we had to shut the city, the two largest cities. No movement out of Nairobi and Mombasa, and no movement into those two cities. Mombasa, of course, is the second largest city. As I told you, Nairobi is the capital city, meaning that, more than half of, of the economy is basically controlled from those two cities. So majorly, all sectors were basically affected. You can talk about manufacturing, transport, hospitality. We had to close all hotels. That's how serious it was. And of course, we closed the markets as well, meaning that most of the small scale traders, and those are the majority of the people, could not meet their daily, requirements in trade and, and all that they were doing in those particular areas. So it was a major thing. It really affected the economy of the country, the economy of the counties. We really had to go, and ask those of us who are able to basically, collect food and some other stuff, and to help those who are rendered jobless, those who are rendered, whose businesses are basically swept away because of COVID, to help them, in their daily lives. So yes, the economy was so much affected.
Yeah, certainly. And I think, particularly in this setting where about 70% of the people depend on daily wage, not going to the market becomes difficult, and social distancing was an issue. But, we're grateful that on health part, you seem to be ahead of most European and North American countries. So that's a good thing, but the economic impact is still there. Lydia, as an insurer, head of the National Health Insurance Authority in Ghana, could you share the impact that COVID-19 has had on your operations, and possibly impacts on treatment of patients and etc.?
Thank you very much, and good morning, afternoon, evening to the listeners. In Ghana, we managed the COVID through government funds. So government of Ghana has taken the cost of the COVID, and it didn't come through the National Health Insurance. The National Health Insurance Authority was able to stay running throughout the COVID, even during the lockdown, to allow those who need care or other types of care to interact with us. Luckily for us, a year and a bit before COVID took hold, we had introduced a self-renewal of the NHIS membership through mobile technology. So during COVID, 80% of the members who needed to renew did self-renewal through their mobile phone. So we kept running. What we did notice is that during the pandemic, utilization of services dropped dramatically. So we had our first case in March. By April, utilization had dropped by 35%, and May still down by 25%. Currently about 10 to 15% down. So we haven't recovered. People are still avoiding going to the hospital. Our normal claims expenses, therefore, have dropped. But we are yet to really analyze and see who stopped going to the hospital and what needs to be done. Thank you.
Yeah, thank you very much. I would like to go to Marion, because I think there's a link between what NHIA Ghana is doing and what the Global Financing Facility is doing, in the sense that it's about ensuring access to, among others, and to mother and child care. And we've learned that, you know, across the countries, at least where we work, you know, people were afraid to go to hospital, mothers and children, because, you know, of the risk of infection. And so, you know, I would like to have your take on how, working with the GFF, how you are addressing some of these challenges.
Many thanks, Kwasi, for this very important question. And good morning, afternoon, and evening, everyone. So I believe GFF raised the alarm around March, April 2020 for this widespread disruption of PHC services as a result, actually, of pulse survey the GFF Secretariat was conducting in the 36 GFF countries. And as a result of this data, we decided to support ministries of health in the 36 GFF countries to really safeguard primary healthcare, essential health services through 3 ways, I would say. Number 1 was to support ministries of health really monitoring essential health services in collaboration with the World Bank Development Research Group, but as well with partners on site. For example, leveraging health management information data reported by health facilities to determine the magnitude of change in utilization levels since, you know, the first COVID case, you know, pop up. Another way was to support ministries of health implementing rapid phone facility surveys to better understand, I mean, to gain more timely and accurate data and provide additional information on the supply side challenges faced by staff at health facility level. And then those data as well were triangulated with supplementary data from household survey, which were showing actually what the constraints were from the demand side, from household, the reason why they were not going to health facility to seek treatment for essential health services. And of course, another type of intervention we supported ministries of health with is resource mapping related to COVID-19 to see if there is a deprioritization of essential health services from a funding point of view. The second bucket where we really supported ministries of health of the 36 countries is the knowledge and learning program, supporting those partners countries to really identify strategic shift, to ensure to safeguard primary healthcare services. For example, through telehealth, role of community health workers, private sector providing FP commodities during those times. And so it was a very interesting process, peer-to-peer exchange, and it really helped creating change. And it was a very action-oriented learning program, I would say, where country participants, as a result of this peer-to-peer experience, would actually develop a change plan to safeguard PHC services. And the last one is simply the technical and financial support for countries to plan, to implement those strategic shifts to really maintain essential health services so address demand constraints from household to go to hospital, primary healthcare clinic to seek treatment for essential health services.
Yeah, thank you very much. Thank you very much. We will certainly come back to some of these things as we look at how countries have used the lessons from COVID to build their health systems. Let me go to Manjiri, working with the Global Fund, where the past 2 decades or so, the Global Fund has done really well, providing treatment, prevention for HIV/AIDS, TB, and malaria. What we've seen during COVID is that there's a shift of resources, from countries at country level to address, COVID-19, which is a pandemic. Then the question is, on my side, the fear is that, as countries shift resources to, from HIV, malaria, and other diseases to COVID, we might lose the progress, that we've made over these years. How do you look at it, and how do you make sure that that doesn't happen?
Thank you, Kwasi, and again, hello to everybody from all corners of the globe. So yes, this is a question we continue to think about and has been asked to us several times. So, Global Fund in a way is in a very unique position because we are used to fighting infectious diseases, right? So we already have a lot of systems in place where we can mobilize and quickly respond to whether it be Ebola or now COVID. So very quickly, Global Fund instituted 3 different facilities. We had 3 different responses for COVID. One was within our grants, a lot of the grant flexibilities, any savings from the grants were immediately mobilized for countries to access for COVID. Then we also set up a financing facility called C19RM, which was additional $500 million to where countries could submit their COVID plans, and we started funding those. And then the third was we were the founding member of an accelerator to access COVID technologies. And then in terms of our response, it was we had a 4-pronged response, which essentially was to, of course, protect the HIV, TB, and malaria outcomes. A lot of progress has been made. We don't want to lose that, indeed. Second was really focusing on protecting the frontline workers, including the community health workers, which really form the backbone of a lot of the support that we provide in countries, especially to the key and vulnerable populations. We rely on the community workers. The third was this was a really good opportunity to also reinforce the health systems, making them resilient, improving the supply chain, improving the lab networks, improving any community-led network. And finally, of course, it was focusing on COVID testing and COVID response as well, which included testing, tracing, supporting isolation, and things like that. I can give you a couple of examples of how it was done in some of the countries. Benin and Uganda, we relied on community workers to provide door-to-door either bed nets or ARVs. So when people were not stepping out to access their services, we ensured that there was some sort of a distribution setup where either drugs or bed nets were delivered from door to door. For example, in Indonesia, we helped them adapt lab facilities that were doing TB testing to enhance the molecular technology to do COVID testing as well. We have been expanding the HIV testing facility, testing capability, not only at the facility level, but now at the community level, and also at wherever infrastructure exists, do some self-testing. We were also expanding home-based care, in many cases, triaging, say, for malaria and things like that. So if people were resistant to going to facilities, we were able to take the facilities or some sort of services there. There was a lot of testing, reinforcing TB screening using digital X-ray and diagnostic instruments. There was a lot of investment in telemedicine. So people could access medical services and medical advice using telemedicine.
Okay.
So those are some of the examples. But yeah, the key is, of course, maintaining the prioritization of the 3 diseases.
Yeah, thank you.
Thank you.
Thank you. Yeah. Diana, for the, so there are sort of 2 groups of people, or maybe more than that, but at least, I come across 2 groups. One say that, COVID is jeopardizing efforts towards universal health coverage. And the other one says COVID is a wake-up call to strengthen health systems. So, working for the WHO and, interacting with countries in Africa, what do you consider to be the key lessons that some African countries are learning from COVID? You are muted. Can you unmute yourself, please?
Yes. Thank you, Kwasi. Good afternoon, morning, and good morning and afternoon to everyone. COVID-19 has indeed jeopardized the efforts and gains made during the last decade towards UHC. And this has more than ever highlighted that building resilient health systems is very paramount. And this speaks to systems that are able to sustain provision and access to health services when faced with shocks. We have witnessed disruptions in health services due to repurposing of health resources to COVID response, and the repurposing of health facilities for COVID-19 case management. And also overburdened health facilities where we witnessed stretched health facilities and community-based workers, and disruptions in the supply of chain system, and shortage of PPEs and closely related to these healthcare worker infections. In East and Southern African countries, for instance, at least more than 37 million children missed vaccination due to postponement of preventive and reactive mass vaccination campaign. We have learned how important is the role of communities as major players in building resilience. Communities are more receptive if approached by people they trust. Communities have been instrumental in mobilizing, in the mobilization of their fellow community members, improving uptake of interventions and other interventions that relate directly to the response, like transportation of supplies. This was seen in countries like Ethiopia. We have also learned how strong partnerships between all government sectors and donors are, especially to ensure for adequate coordination of the response to the pandemic with sustainable and accountable resource management for equitable response to the population needs. Multi-sectoral approach is also a prerequisite for effective response, with holistic integration of strategies to address related social determinants of health challenges and sustain gains that were made towards the SDGs, including UHC.
Okay.
Thank you.
Yeah, thank you very much. Thank you very much. Matthew, if I could come back to you, still on this point that COVID is a wake-up call to strengthen health systems. I know that in 2018, the president of Kenya declared UHC to be a national priority, and Kisumu County is one of the pilot counties where UHC is being done, and you've been key in that effort. Could you explain some of the progress or share with us some of the progress that you've made so far Could you unmute yourself, please?
Thank you. The president was elected into office in 2017. And of course, the governor, that was in August. And so in 2018, he did decide that he will have UHC as one of his key pillars of his administration.
Mm-hmm.
Kisumu was chosen, just like you said, to be one of the 4 counties in Kenya, piloting UHC. So the first thing we did is that we registered all our county residents, more than 3 million of them, into a UHC platform through a mobile app or a mobile platform that we're calling MTIBA. Okay, M for mobile and TIBA is basically treatment. So we call it TIBA. Now that registration also included a socioeconomic survey. So by the end of it, we got to know how many residents within the county of Kisumu are indigents, those who are not able completely to pay. Okay, but okay, the UHC program would, take care, of each and every. So long as you're registered, you go to a facility, you are not supposed to pay even a single cent. So after the registration, normally what happens is that those who have registered get what is called a health wallet in their phone. Okay, that's after registration. And in the pilot phase, just like I've said, we are meant to offer completely free service to the people. Now, this ran into headwinds, okay, because we had serious issues, implementing this program. Many times people will go to facilities and they find one or the other thing missing. So they don't really get that free service. They have to get out of the facility to be able to get help. But we all know that UHC is a great idea. It's an idea that should really concern each and every government. But the sustainability is the issue. We now believe from our experience that the only way to make it sustainable is to offer social health insurance through the National Health Insurance Fund, which we have in Kenya. We call it NHIF. This way, we can secure the health system, okay, by addressing what we believe are critical pillars in healthcare. That is manpower, human resources for health, especially the commodities that we need to use in the facilities, governance of the same, information system, and of course, monitoring and evaluation. As a county, we are still very committed, by the way, to this process. And I can report, of course, on behalf of our county and the government, that the first phase was just kicked off last month together with our partners. And we have the first half of the indigents of the county of Kisumu who will be benefiting, okay, from the partnership that we have with the insurance fund, the county, and of course our partners, PharmAccess, okay? So that begins on by 1st of December this year.
Okay. I will come back to this, on the specifics later on. So if you permit me and I think it's wonderful that within this period that you have launched health insurance, really emphasizing the need to strengthen health systems, have a more sustainable approach, and not only in dealing with COVID-19, but the next epidemic, but also, provide decent healthcare. We will come back to some of the specific things that you have done in the course of this event. Manjiri, I know that, Global Fund is focusing on HIV/AIDS, malaria, and TB, but we all also agree that, a sustainable approach to UHC is important, and to also address some of the Global Fund focused areas. And just your take on, as you go around, the countries, have you come across some exciting stories from countries, on this journey towards sustainable financing and delivery of UHC?
Thank you, Kwasi. Very interesting question, indeed. So yes, as a matter of fact, we do have some examples, and this is increasingly on our agenda, to engage with national insurance schemes in different countries to integrate HIV, TB, and malaria services in those. that, this is an ongoing conversation, right, between vertical programs and horizontal health systems. And I think that we need to move away from that conversation and ensure integration and transversality of the services we provide. So I have a couple of examples that come to my mind that have been quite successful. They're both in Asia. In Vietnam, actually, we in 2014, the government had decided, 2014 or 2016, they had decided to expand their health insurance. It was pretty, about almost 70% of the population was already covered. And then we also, later at some point, the government decided to integrate HIV services, ARV testing, of course, viral load testing, and dispensation of ARV drugs. So the way we work very closely with PEPFAR as well. And for some time, until the government was putting things in place and was able to cover the HIV positive population, PEPFAR was covering some of those premiums. And then we had Global Fund grants as well, paying for some of the other remaining about 32,000 PL-HIV people. And over time, we can say by 2020, PEPFAR has been able to transition most of the patients that they were supporting, and the Global Fund grants were supporting. We were able to transition most of those onto the government. So that was a very successful example of expanding the services to HIV positive patients, and as well as including HIV services into the program. We're now in the process of having these similar discussions with Indonesia. They have one of the largest JKN in their national insurance policy scheme, and the Global Fund is in quite high-level policy discussions with the government to ensure including HIV and as well as TB services. And then another one is Thailand, where because of the Thai economy, it gets a lot of migrant workers. And what has happened is the HIV or the prevalence and new infection rates of the three diseases is pretty high in these migrant populations. So there's a risk of spreading that into the rest of the population. So Global Fund, again, was very engaged, involved, leveraged our grant monies to negotiate and help the government set up a migrant health insurance scheme, which has actually now, expanded and enrolled a lot of these migrant workers, and therefore you can see the health outcomes of these migrant workers are also being, improving. So some of these are examples that I can think of that have really helped in ensuring the services for these three diseases are institutionalized within the country. And UHC and national insurance is, of course, the way to go, because then either it's tax-based or payroll deductions from payroll. So in a way, it has a dedicated funding stream. It has services, so it's integration of services as well, and expanding the coverage. So we continue to have these conversations in as many countries as possible. And it's over the continuum, many different countries we have worked in, but these are three really good examples.
Yeah, no, certainly. And I also come across countries which are saying, let's build our mechanisms locally such that, you'll be able to deliver, universal health coverage and TB and malaria on a long-term basis. So these examples are very interesting and encouraging also for countries, which are embarking upon this journey. Diana, at the end of the day, there should be money, to finance all the good ideas that we have. And I know that at the WHO, you've been involved in resource mapping, leveraging data to improve financial sustainability. But I would like to talk to you more about the work that you have done on national health accounts. What we've done and how is it helping countries to be financially sustainable?
Thank you, Kwasi. Sustainable financing, first of all, for health is the one that relies more on domestic resources, more the government, and with less reliance on household out-of-pocket expenditure, which are seen to be a regressive way to finance health, and with efficient management of the available resources. To achieve this, key challenges observed in African countries are mainly limited fiscal space, and as a result, not able to raise adequate funding for health, low tax revenue base in majority of countries. The other challenge is unbalanced investments and high reliance on external aid. And also in some cases, sustainability considerations are not well planned for when developing projects, and once these close, and government funding is inadequate to sustain gains. There is also another challenge on weak evidence base to guide dialogue between ministries of health and ministries of finance. So with regard to the evidence and data to inform financing policy decisions, the National Health Accounts, the NHA, is a tool designed to assist policymakers in the efforts to understand the health financing systems and to improve health system performance. It reflects the main functions of health financing, which are resource mobilization, pooling and insurance, purchasing, and also distribution of benefits. For the last 2 decades, WHO supported African countries in institutionalization of national health accounts, which is like within the 4 dimensions of financing sources, financing agents, providers, and functions. And mainly the key support was building capacity in health financing in general, but in NHA in particular, and also providing technical assistance to countries to produce periodic national health accounts, national health reports, and supporting the institutionalization towards improving its demand and use, and also production of national health accounts, dissemination and transformation of those data into useful information to health financing decisions.
Okay.
Countries are at different levels of institutionalization. So we have important ongoing works. WHO Africa region, we are supporting African Union to develop tools and modules towards development of Africa scorecards on domestic financing for health. We are also working on a regional guide for the NHA institutionalization using lessons from countries and views from global experts. This will be shared.
Okay. Yeah. Okay. Thanks. Yeah. Thanks. I think I'm looking at my time, so we got to look at another important element of this discussion, and that is the role of technology and data. Yesterday, Lydia, we were talking about data being the new gold or oil. And I felt that if you are from East Africa, you might perhaps say data is the new coffee, right? Because it depends on where the resource is. Lydia, so if I may start with you on this point, I know you've been doing a lot on digitization and data analysis. Could you share with the audience what you've done there and what the future looks like for NHIA?
Thank you very much. Obviously, it's important to digitize our membership. That was the first goal. So we have a biometric database of which 23 million out of the estimated 30 million people have been captured from 3 months till death. And this allows us to know where everybody is. You can renew yourself with mobile technology. Ghana is now rolling out its national ID card, so we will link up with that to use the national ID for health services. The visits are also authenticated by mobile technology so that we at the health insurance have a rough idea of who is utilizing the services where and at what time. This allows us to be a bit better prepared for claim submission. The claim submission is now also getting more and more digitized. We started off manually, and now more than 30%, especially the major hospitals, the tertiary and secondary hospitals, all submit their claims through digital means, and it's processed that way. It allows us to do analysis and see, have a better idea of what is going on, what the cost drivers are, and therefore we can use interventions to try to look at that. Our credentialing for the hospitals is also online. Everybody applies online. If we need to inspect because there are some discrepancies, we do so. So on the whole, we are trying very hard to go as digital as possible. But that allows us to make, I think, better interventions when that data and its analytics are shared with the stakeholders, especially the service providers and the ministry that makes the policy. When we all look at it, it allows us to better understand what is going on. And the other thing I want to say is when we started, we had very little digitization. But once you share your analytics with stakeholders, then there is that interest to provide better data, and so it goes on. So each few years, there's more iteration, and we get more digitized. The quality of the data is better because people appreciate what you are doing with that data or what that data means. So I think in that regard, that is what Ghana is trying to do in the era of data.
Yeah, certainly. And I think it's something that is also of relevance, for other African countries, which are embarking on national health insurance as a means to address USC. So we will come back. I've seen some questions coming in the chat on data and insight. We will come back to that. Mario, so the GFF is collaborating with WHO on the resource mapping, and we've heard from Diana on the health account side. Could you share with us how the data, coming out of the resource mapping is helping in prioritizing essential services and ensuring efficiency in healthcare spending?
Kwasi. No, thank you for this question. And indeed, so we are working very closely at country level with WHO and Diana's teams. So first of all, so I get very excited about resource mapping because I think it's a very powerful tool really for decision making. And I think there are several use cases. But first of all, resource mapping, it's simply mapping budget expenditure data against costed national health plan or investment case. And so there are several use cases, out of the data coming from this exercise. So the first one, I think it's really a tool which can foster domestic resource mobilization agenda. So the Ministry of Health does the resource mapping of essential package of health services. This essential package of health services says cost $100, and the Ministry of Health can only put $60. So there is a funding gap of 30%. And so then the Ministry of Health with that can go to the Ministry of Finance or to donor and say, look, to really reach our maternal and child health targets, we need to close this funding gap, So it's really a tool by which ministries of health can go to Ministry of Finance to advocate for more resources. But I would say beyond the DRM agenda, I think it's really, it can help them with prioritization. Because what we've seen in some GFF countries actually is that, the first result is that the funding gap for an essential package of health services or their key PHC priorities will be huge. Perhaps 90%, 80%. And so it's a reality check. And perhaps, the Ministry of Health and partners were too ambitious, with the targets to be reached. So it's really helping ministries of health to prioritize further, but as well donors. A third use case, I would say, is more around fostering the efficiency agenda, which is very important in low and middle income countries where resources are scarce, right? And I would always remember one of the resource mapping results, and it was in DRC, and we realized that some interventions like HMIS were actually overfunded, while other interventions were actually underfunded. So it's really stimulated discussion among ministries of health and partners on really allocate resources where the needs are. And what we saw as well is that in other regions, for example, where the health needs were the highest, there was very little funding going on, perhaps less than $1 per capita. So that's really a tool by which it fosters more evidence-based resource allocation formula, I would say. Another use case is really helping ministries of health monitoring implementation of their national health strategy. Perhaps, with this exercise, they will notice that the government, but as well other donors, only disburse 20% out of what they said they would be disbursing much more. So it's a tool to monitor the implementation, but as well, it's an accountability tool for CSO, for instance. And of course, in the context of COVID-19, what we have been trying to do with WHO colleagues is as well support ministries of health with COVID-19 resource mapping. And one of the use case, and I mentioned that a little bit earlier, is really looking at whether yes or no, there has been reprogramming of funding from essential health services to COVID. And we have seen that actually happening. In DRC, for instance, reprogramming funding from essential health services to COVID has increased from 6% in April 2020 to 35% in July 2020. But if you don't have this data, you don't know about it. So again, this is really important to do those resource mapping to better prioritize essential services, but as well to ensure there is no deprioritization of health services happening.
Yeah. No, it's important that we leverage data. And so, it's one of the passions of my organization, PharmAccess. How do we leverage data to enhance financing and delivery of care? And talking about that, Matthew, I know that you've done some amazing work on this in Kisumu. And sometimes I feel like Kisumu County is too modest in sharing this work. So you've done work on poverty mapping, using digital tools to enroll and analyze data, but also leveraging digital platform. I give the floor to you. Please share with us what's happening there. And how all of us can learn from it.
We are actually in the initial stages. There's a lot that we can learn, even from this system that we are already implementing. I did mention earlier that we have the MTBA platform through we did a socioeconomic survey of the rest of the county of Kisumu. So now we know, where the poor live, for example, and who and how many households, for example. But furthermore, we have run out of that a pilot with the digital system where we have all this data loaded onto what we call a UHC dashboard, okay? So we can monitor many issues. One of the things that we're monitoring are the disease patterns. We're also monitoring on the medication. We are monitoring the cost of care. This is very important, by the way, because health financing normally can be a very expensive, affair. We're also monitoring the trends of utilization. Now, this dashboard we are talking about will be accessible to the county at all levels. We have 47 facilities where, apart from the county having this dashboard, the 47 other facilities also have the same, dashboard to monitor, all these parameters that you're talking about. Now, the dashboard will also be able to help us make informed decisions when we are allocating funds. It will also help us to evaluate and also to plan, for the future, and in case we need to do anything apart from what we are currently implementing. Now, quality is a major thing in UHC. We can also be able to tell, from this dashboard whether, we are, providing quality care to those who visit our facilities. We have a quality assessment digital tool, which we are calling Safe Care for COVID, okay, which we have sent out to all health facilities in the county, and we can be able to now assess, our preparedness for COVID. Now, they receive an immediate quality improvement report, okay, out of the system that we are engaging as we speak. Now, we can also follow the same through a quality dashboard within the county, okay, at the center, okay. So all this is, is happening. Now, we also have bulk messaging, okay, to these people all over the county, the 3 million of them. So we can keep, informing them of, the current trends, and also to just remind them not to lower their guard at this point. We have a call center where people can call in, and we can be able to tell, from which direction or from which facility or from which area. So we can be able to link them for help as soon as they need it. Now we have an app that we're calling the Lucy app, which they can use also to do a self-assessment, okay? So that if they are, having symptoms, they can be directed, okay, to the next facility so that they can also get the help that they need, okay? So we have quite a number of, information, okay, within the county, quite a bit of data that is very useful in this period when we are, fighting the COVID pandemic.
And you've been doing this with PharmAccess,
we are doing this with PharmAccess. They are very valued partners. Right from the beginning, by the way, when we were implementing, we were partners with them when we were collecting, through the MTIBA platform. So we are indeed doing it with them majorly.
Yeah.
And of course, NHIF for the component that we are covering.
Certainly partnership is key. So,
very, very
whether
key.
it's with a development organization or with a private sector, or others is quite key. And with that, Manjiri, I know that you have to leave because of a prior engagement, but on the partnership side, do you have some examples that you can share?
Absolutely. I think partnership is our DNA. As you know, it's a partnership model, the Global Fund. So we rely on all sorts of partnerships. So we have, it's a financing mechanism, so we can bring the money, but there's so much more that we need on the ground, as well as globally, to ensure we make some progress towards our health outcomes and the disease outcomes. So if I was to think about it, we could think of 3 or 4 different types of partnerships that we maintain and foster and actively engage in. First, of course, is the technical partnership, where we rely on technical partners like the UNAIDS or WHO for our coming up with the norms, treatment norms that countries will implement, that we will finance. We also rely very much on the World Bank and IMF for any of the financing and analytical products or technical assistance on health financing reform in the countries, including, of course, GFF. We have been partners with them in several of the countries. We have other types of partnership with bilaterals, particularly PEPFAR and PMI. where we jointly plan our disease programs in these countries and jointly ensure that our financing is also aligned and that there are no gaps left in countries. And PEPFAR also, the scope is very wide in many countries. So they are strong partners for us. Then, of course, one of the most unique characteristics about the Global Fund is our civil society partnership, right? Not a lot of donors can actually say that they engage very meaningfully with the civil society in the way that we do. Through our CCM, we've empowered the civil society to be a part of really high-level conversations on the diseases, and for the first time, they also have access because of money, access in the CCM with their voice and also money to make a difference. We engage with the civil society also for social contracting. They are very vital in providing services for key and vulnerable populations and hard-to-reach populations. So in many countries, particularly transition countries, we're looking at social contracting, where governments would contract with civil society to provide these services, and Global Fund has been instrumental and catalytic in that. We rely on civil society for advocacy for HIV or the 3 diseases, advocacy for increased domestic resource mobilization. And then, of course, we also have the private sector, where we have all sorts of relationships. I was just looking at one very recent example where we're working with MasterCard in Rwanda, actually, to bringing that level of digitization and interoperability of data at the health facility level. And we're working with MasterCard in bringing that to piloting that in Rwanda. Private sector has a lot of technical knowledge of implementing many different types of programs, be it initiatives, be it supply chain, or be it data management. So we try to partner with them as well. We, of course, have a lot of collaboration and relationships with PharmAccess. So this is our model. We don't have feet on the ground or ears on the ground, so we rely on our partners in different forms to implement our objectives.
Yeah, thanks. I have 2 questions here related, and I think I will ask that to Lydia. So you spoke about data and technology in HIA, and the point here is, could you give examples where data insight is helping you make better decisions? And then the other one relates to privacy. As you get more data, how does NHIA ensure the privacy of people, at the same time optimizing the data to improve its operations?
Thank you very much. I think the balance between how big your benefit package is and financial sustainability is critical. In some of our countries, we have to be honest, the political economy sometimes outweigh financial decision-making, if you will, and we end up promising things that can put us into a bit of trouble, and it's very difficult for the technocrats to say no to the politicians. We have just recently, with the assistance of the Global Fund, built an actuarial model, and we are putting in the data and all the costings for us to be able to really show the evidence that maybe we're not quite ready to provide this particular service in this particular way, or then we have to advocate for more financing or something. So in that regard, we are able to use the data to give evidence to the politicians before they make some of these policy decisions. We've recently looked at family planning. It had its own vertical program, and we did some actuarial studies. Then we did a pilot, and it looks as if we can put it into the benefit package without having any problems with sustainability. So it's now being discussed for nationwide scale up. So that's an area where we were able to use the data and a pilot to let the politicians understand the implications and what we need to do to scale up. Talking about privacy, I think that's a big issue. For us, we try to be sure we are ISO 27001 compliant, so that all our systems or new additions to our systems must be compliant. Ghana has a data protection commission, and agencies who hold personal data must be signed up to it, and they must sign you off as being compliant with all the latest protocols. I know that doesn't guarantee anything. We've seen bigger companies than ours get hacked or whatever across the world. But at least I think there are ways and means to try to protect the data, especially those of us who hold personal data of our citizens. And I think we have the biggest database on the citizens of Ghana. So we are really trying very hard to, everything has passwords and firewalls and the rest of it. And we've just recently had an ICT audit to really advise us on any gaps or loopholes that we quickly have to plug. But I think, yes, it's a challenge for all of us when you're looking at health data to make the necessary effort to ensure the data is protected. Thank you.
Yeah, thank you very much. Matthew, there's a point here, and I think it's related to the work that you've, you know, what you said around USC and all the digital tools that you're using. And maybe I think you emphasize it, but if you could emphasize this more here, the question says, how do you ensure that you are leaving no one behind? And I think part of the work that you're doing with PharmAccess on the poverty mapping, I think it's a good example, but please go ahead.
So thank you. We do not want to leave anybody behind in the UHC program. So for those who are able to pay through the social, health insurance that we're having in the country, we have passed a bill within our county assembly, which is now our Kisumu County Health Act, that makes it mandatory, by the way, for people to pay into a social health program. Now, we also have those who are poor and are not able to pay. And we have a partnership, just as I mentioned earlier, between the county, NHIF, and PharmAccess, to be able to ensure that the county pays for this segment who are not able to pay completely. But we also, subsidizing for some segment of the population. So there are people who will pay because they have a means to do that. There are the other segment where we will subsidize, okay? And there's a segment of our population where we have to pay, the whole health insurance for them. Meaning, therefore, that within the county of Kisumu, no one is basically being left behind. Because even for those who are not able to pay, we have partnerships, okay, and government allocations to be able to pay for them. Mm-hmm. So that's what I would say.
Yes. And I think underlying the idea that no one is left behind is how you are leveraging data. And so on the poverty mapping, and the idea that, you are able to segment people, on the ability to pay or not, I think is crucial. And because at the end of the day, we all agree that, somebody will have to be subsidized, but the government doesn't have enough money. So how do you ensure that the limited resources that you have are targeted? And I think that that's really a very nice example of using technology to segment the population, in that way. Thank you. Marion, I'm very much interested in the relationship that GFF is building with local institutions, because it's about ownership. and particularly if you have examples to share with us on whether it's on the private sector or on development organizations to ensure better health outcomes. I know that you work with government, but besides that, you know, how do you go on in collaborating with non-state actors to ensure the work, successful implementation of your work?
Sure, Kwasi, thank you. I think I will, you know, maybe to build on Manjiri's example, I will provide some example on CSO, because it's true that as part of the country platform, so you have government representatives, you have private sector representatives, you have partners, but you have CSO. And CSO, I would say, have been critical really in you know, supporting the sustainability, I mean, the sustainable health financing agenda. And perhaps I can just mention two country examples where really we have seen a big impact of their role in this area. The first one in Côte d'Ivoire. So in Côte d'Ivoire, there is, I mean, there was and there is still a health CSO coalition, which really contributed to the development of the investment case, the national, I mean, the prioritized national health strategy of Côte d'Ivoire. And so they really led capacity building activities, and they were coordinating as well community feedback around the development of this investment case, but as well around the domestic resource mobilization agenda. And, you know, they were reaching out to MPs and to different networks to really to push for this domestic resource mobilization agenda. And as a result of that, and as well as a result of other analytical work going on that we supported, but I would say really as a result of the push of the CSO toward, you know, this DRM agenda, this really contributed actually to a 16% increase in the country, you know, 2020 health budget. So we could really, I mean, in Côte d'Ivoire, the role of the CSO was quite critical in this area. Another country in Senegal, so there, the GFF CSO coalition is supporting the Ministry of Health to monitor the investment case implementation in several regions, actually the regions where the health outcomes are really lagging behind. And so CSO advocacy to increase domestic resources for health has led, very interestingly, to local mayors committing budget towards family planning and to religious leaders calling for a percentage of mosques' revenue to fund health programs for mothers and children. So, you know, again, in this specific context, the role of the CSO was kind of crucial to drive, again, this domestic resource mobilization agenda.
Yeah, thank you. Diana, I know you have some nice examples from Rwanda about how they're using digital technology to collect and analyze data for financing and delivery of care. Could you share that? And yeah, please.
Yeah, Rwanda has extensively invested in digitally enabled socioeconomic interventions. And for health, it was developed through several health information systems and tools during the past years. Specifically for health financing data, Rwanda focused on the use of digital technologies and efforts to improve harmonization of the health financing data systems. And this relied mainly on the leadership and required strong partnerships between different institutions and actors, including health economies, health financing experts, and information technology experts. So the country has invested in innovations and different IT systems used by the government of Rwanda to track resources. They integrated the IFMIS, Integrated Financial Management Information System, located in the Ministry of Finance, and the Electronic Medical Records, EMR, based at Rwanda Biomedical Center, which is an implementing agency of the Ministry of Health, and the health resource tracking tool from the ministry. So the key reforms, the key reform was based on harmonization of all those three key tools, IFMIS, EMR, and the health resource tracking, HRTT, through mapping of national health account classification and adequate understanding of indicators needed to comprehensively track the flow of resources from their sources to the point of service for all intervention. So responding, for example, if MIS and EMR were enhanced to produce national health indicators in response to questions such as who finance health activity in Rwanda, who does the country raise funds, and also who manages the funds, provide the services. So the EMR initially was like collecting specific information, and it was enhanced towards contributing to the health information systems that were producing, contributing to national health account. So great progress were made on improving Rwanda health information system. And for example, the interoperability between the three tools, and also the reduction of those expensive and time-consuming periodic surveys. It has contributed to the reduction of that type of data collection and information.
No, certainly there are interesting examples to share, but I look at my time and we have 5 more minutes to go. So I think we will, and questions are also coming in, but I think we have no option than to conclude. So concluding this session, Matthew, you're doing great work. What will be your advice for other countries in Kenya on the path that you're making, but also for the West Africa where I'm from, because you have countries which may think they are too small to embark on both strategies, and particularly the benefits that you've seen by using technology.
Well, from this end, I think that the major lesson that we've learned is that one way or another, we need to ensure that universal health coverage becomes a reality within our communities. That is the only way that we can be able to ensure that no one is left behind. And for that to happen, we may need to leverage on technology so that there's proper data capture that is needed, so that when you're finally rolling out universal health coverage, you have your data, and so where to put funds, and who to bring along. I think it is also important that we pass the necessary legislation. I did talk about the Kisumu Health Act, that makes it mandatory for people to contribute into a social health insurance scheme. Without that, it may be difficult because it can be challenged in court. So once that is done and it is, passed and the act is in existence, then that means that, those who are working and are able to pay will pay for themselves. Those who may not be able to probably pay the full amount, the government should be able to give that subsidy. But I think it is incumbent upon all governments to think about those within their jurisdiction who are not able completely to fund their healthcare. We must ensure that they are brought into the bracket, and that they, because health is a basic human right. I think it starts from there. And to ensure that that right is not infringed upon, we need as governments, and as health partners, to ensure that this particular segment of the population, we're not just talking about the poor people, we are also talking about even people living with disability. Of course, there are those disability who can also be able to pay for their health insurance, okay? But there are those among them who are not able to pay completely. So governments need to get on it. They need to look for good partners, like the partners we have, PharmAccess Foundation. And I believe the world becomes a better place if we mind about those who are not able.
Yeah, thank you. And lastly, Lydia, you've been an advocate for a leading voice, I should say, in how digital technology can help reach everyone. What's your advice to your fellow national insurers in Africa who are hesitating, and also for listeners to embrace this journey?
Thank you very much. I think it's important we think outside the box. And listening to my colleague from Kisumu County, leaving no one behind means we have to use innovative ways to capture everybody. PharmAccess, for instance, has helped us link with Ghana's National Household Registry, which has those who need social protection in there, so that we can give them a free health insurance card and maintain their membership just by linking up with their database. This is how technology helps. I don't think we need to be super sophisticated to be able to start using technology. Everybody in Ghana has a mobile phone. When we started the mobile renewal, we thought it was the cities who would take it up. It was the rural areas who took up the mobile renewal first, because they don't want to be traveling long distances to our office. Everybody has a mobile phone. So, and the network is very good. So what I'd like to tell all of us is it can be done. We just need to take it step by step. You start, it gets better. Before you know it, we're running paperless health systems. Thank you.
Yeah, thank you very much. I think, our time is up. There are more questions to be asked, but we have to end here. So I would like to thank you all for the panelists for your time and the preparation that you put into this webinar. Marion, thanks a lot, Dr. Matthew. We're really grateful for the work that we're doing together. Diana, it was exciting to work with you on this. And as always, Lydia, an important partner for the work being done in Ghana on insurance. So thank you very much. I don't need to summarize. I think the message was clear. And I also like to thank the audience which tuned in. So until next time, have a nice evening or day. Yeah. Thank you very much.
Thank you.
Thank you, everyone. Bye.